So good afternoon, ladies and gentlemen. Very happy to see you again here in this conference. I'm an IR, and today is a good experience for me to share what we are doing in our hospital. So thank you, Dr. Orpin, for a very nice presentation highlighting the endovascular treatment. So I'm not going through the literature as well, but I'm going straight to what we are doing in our hospital, how we contribute, how we collaborate with the clinician in the management of diabetic foot ulceration. Let's have no disclosure. So as we may know, the diabetic foot ulceration, let's say DFU, is one of the most serious complications of diabetes and one of the leading causes of non-traumatic low extremity amputation worldwide. And every diabetic patient may experience DFU in a lifetime around 1/3 of the population. And there is a 50% of the DFU is associated with ischemia. And we say there's an interaction among very multi-factors like neuropathy and PAD, trauma, and impaired wound healing. Most of the patients come at the late stage with a poor prognosis and high risk for amputation and mortality. So let's take a look at the vascular characteristic of DFU. From the macrovascular, there's a predominant distal distribution, mostly of infrapopliteal artery involvement, multi-level occlusive disease, diffuse and long segment lesion, and sometimes you can see the medial arterial calcification that we say that is a monkey buck. So revascularization is a cornerstone for limb salvage. Let's see the pictures. It's quite different from above and below the knee lesions. From above the knee, the nature of the lesion is quite scarce, from CTO, calcium, thrombus, soft plaque. But for below the knee, most of the lesion comes from calcium, more than 75%. So when we are doing BTK intervention, so we are facing with the hard rock lesion. You also know that there is a Wi-Fi staging for DFU, including the tissue loss, ischemia, and infection. So for every kind of patient, we usually discuss with orthopedics and diabetics, or what should we do with the best for this kind of patient. As a radiologist, we usually relied on the finding on the CT angiography at the set of the plant. So on the CT, the clinical findings of DFU and the PAD in diabetic patient are usually multi-segment CTO with a heavily calcified lesion, and mostly below the knee and affect multiple vessel. And on the CT scan with the 3D reconstruction, it's very good for planning. What should we do for endovascular? We're going to do retrograde or antegrade, or we're going to do bypass. So I asked AI to create this diagram for me, and this is what AI gave me. That is the multidisciplinary management of diabetic foot. So as a vascular specialist like you guys here, vascular surgeon, cardiologist, and IR, we also play a role in an overview of the treatment of the diabetic foot. So for endovascular approach, we can have from a simple POBA, from drug coating balloon, from wellness stent, from drug coating stent, and more recently, as we just implemented from our hospital, that is atherectomy device plus DCB. And our goal is to we set up some different goals for limb salvage, for preservation, amputation, or flap reconstruction. So that's what we discussed with the clinician. So let me share some of our cases. This is a patient, a 66 male patient with the GM2. He has a right heel ulceration with a mild tissue loss and infection. So on a CT scan, you may see a long CTO, long occlusion of the PTA and the shock segment occlusion of the deep dorsal artery. So the CT is very good for planning. So in this case, we want to do antegrade puncture and try to recanalize the PTA. So an angiogram, I made this kind of pictures. So you can see most of the SFA looks good, looks normal, but below the knee, there's a problem. And based on the angiosome finding, we confirm there is a big problem with the PTA, the severe stenosis, and distal occlusion. And this is the heel with the infection. So with this kind of patients, I think in your experience, what would you do? We want to do antegrade or retrograde. At first, we try antegrade first, but it failed. And then we try retrograde from the distal PTA puncture, and after that recanalize and use a simple proba. So after recanalize the PTA, we're going to go transpedal recanalization of the dorsal artery and try to balloon it. So from that point, so I think we can complete recanalize both the ATA and the PTA, and the patient has a very good, quite acceptable runoff on the completion angiogram. So this is an example of the limb salvage. The patient get improved. We check again the color Doppler ultrasound 3 days after the procedure, and you can see on the ultrasound there's a pattern of the all of the 3 vessels. There's another case with a severe DFU in a 80 years old female patient with a long history of diabetes and hypertension. She experienced this kind of food 3 months ago, but just left untreated. For the Wi-Fi classification, there's a high grade, right, with the 2, and on the CT scan, we can see the very poor runoff. With the most affected artery is the BTK. So at first, and with this, the patient, the orthopedics has a plan for a major amputation above the knee, but we have a discussion. So if we can do recanalize, so they can change the plan from this kind of just minimize the amputation. So on angiogram, so you can see that again the SFA looks good, but the most of the problem comes from the BTK. Here's the ATA, the severe stenosis, PTA also severe stenosis, and there's also the almost there's no perfusion in the distal toe. So our plan is that we just try to do a good vessel preparation with the POBA, and then we do a drug coating balloon along the SFA, and then go to the BTK. We do balloon angioplasty from the PTA and also the ATA until the deep dorsal artery. So this is a completion angiogram. So that is much better revascularization, and on the so we believe that the perfusion to the foot is much improved, and on the date of surgery, the clinician changed the plan from major amputation to minor amputation. So the patient is happy, clinician also happy. And you see, during the operation, the clinician that told me that the perfusion is quite good. There's a lot of blood comes from that. I don't know much about orthopedics, but they say that this is a good revascularization. There's another case of a flap reconstruction. So this is the 55 years old female patient with again long history of DM2, erythropoiesis, and major tissue loss. The DFU Wi-Fi is a 2. On the CTA, there's a multi-level occlusion, and again mostly the BTK. So if you are working with the BTK and the DFU, this is very common finding, the common patient for you, right? So on the CT scan, on the 3D reconstruction, you can see that most of the problem comes from the BTK as usual. So we do the angiogram, the SFA looks good, but here on the BTK, there's only the ATA from the proximal ATA, but the distal ATA is also disappear. There's no PT, no perineal, and there's a lot of collateral. So, and again, we try to do recanalization of the PTA and try to go down again to the ATA and try to connect both of them. And after that, here's a completion angiogram that is much improved the perfusion to the foot. And several days later, the patient got successful flap reconstruction. And the last case is about a new procedure for us. We just did it in early this year, and we would like to share with you guys. This is a male patient with a collocation and diabetic also. He has a root of 4, but still the DFU is quite not so bad. So on the CTA, you can see that the severe calcification along the CFA, SFA, and BTK, because our target is this severe lesion. So in this kind of severe lesion, and asymmetric. So we prefer atherectomy with the directional atherectomy device. So an angiogram, we check the several direction. You can see that there's heavily calcification and also occlude the entire lumen. And at first, we try to cross the lesion and put the spider FX, the protective device, down the stream. And after that, we use a tuber hawk device. And oops, sorry. So here's the tuber hawk device. And try to debulking. And yes, with this technique I learned from Singapore. So after that, we try to maximize the lumen gain. So we took the balloon, and finally we decided to put another balloon expandable stent here. I'm not sure you guys would do that or not, but the final angiogram show the complete lumen gain, the maximized lumen gains with and preserve the runoff. And here is the calcification and the calcified plaque we can put. And here you can see on the filter, so we catch a lot of fish, right? So here's our message. Just what we just to share with you what we are doing in our hospital. The DFU is a severe complication of diabetes, and it is a multifactorial and cause a high risk of amputation and mortality. So timely diagnosis and management is crucial for the patient. We think CTA is very good for diagnosis, grading, and planning. The clinical finding, classic finding are BTK, multi-level, multi-vessel, and heavily calcified lesion with a poor runoff. And revascularization is crucial for limb salvage, and sometimes not only for limb salvage, for preservation, amputation, and flap reconstruction. And the last point is the multidisciplinary approach is mandatory for the patient. So thank you for your listening.